everyone, my name is Adina. I'm Specialty Career Webinars Lead with Mind the Bleep. Thank you very much for joining us this evening. I'm happy to introduce Dr. Miriam Broughton, an Obs and Gynae trainee and the North West Deanery. She's here to give us a talk about a career in Obs and Gynae. Over to you, Miriam.
Perfect. Thank you very much. I'll make this full screen. Lovely to have you all here this evening. Thank you very much for joining. I know it's like late on a Monday night, but yeah, thanks everyone. As Dean said, my name is Miriam. I'm an ST1 in Obs and Gynae. So I've put together this talk, hopefully going to cover everything you guys need to know. I'm more than happy to take questions at the end, so you can either pop them in the chat or just keep them in mind and we'll chat through them at the end. I have to bear with me, I've done a full day in antenatal clinic, so my brain's a little bit fried, but hopefully this is useful for you guys. And yeah, feel free to keep your questions. So what we're gonna, oh sorry, can we just move on to the next slide? Thank you. So what we're going to cover this evening, we're going to look at a day in the life and a bit of the variety of what you can expect working in Obs and Gynae. And then we're going to go through, if you're interested in Obs and Gynae, how you're going to apply for it and all the stages in that. Then we're going to talk through the training pathway. So when you get onto Obs and Gynae, what does your future look like? And then finally, we're going to talk through how, whatever stage you're at now, like how you can build a standout portfolio to ensure that you definitely get that place. So if we go into the next slide. Just thought I would cover a little bit about me, so you know who I am. So I graduated at Lancaster Med School in 2022, and then I did my F1 and F2 years at Preston. So these were rotations I did. I did vascular surgery, which was awful, ED, which I really enjoyed, gastro, Obs and Gynae, which was obviously my favourite, then GP and diabetes and endocrine. And then I managed to get straight on to training from F2, so I didn't take a year out. So yeah, now I'm 6 months into my ST1 training. I didn't always want to do Obs and Gynae. It was towards like 4th, 5th year of med school, I started to think that I quite liked it, but I wasn't entirely sure if I was sold on it. So I decided that I would try and get an Obs and Gynae job in my F2 year so that I could like really test it out. And when I did it there, I just really, really enjoyed it. So that's why I decided to go for it. The reasons now that I love Obs and Gynae is this mixture of medicine and surgery. And I know that's really, really cliched, but it's really true. And I think especially given that the demographic and the population is changing, the fact that Obs and Gynae is also medicine is actually really, really true. So we're getting a lot more obese ladies having babies, a lot of people with complicated medical conditions, a lot of people that are actually older in age compared to what we used to have. So I think in terms of that, you actually have to have a really good understanding of medicine and managing medical conditions and the change in physiology in pregnancy compared to outside of pregnancy. And then obviously we've got the surgical aspect in gynae theatres when you're doing cesarean sections, but also like it's really hands-on with lots of like practical things. So if you're somebody who likes like get stuck in doing things like your instrumental deliveries and your suturing, then Obs and Gynae is great. It's amazing to be there for literally the happiest moments of people's lives, but then also being able to walk with people through some of the hardest times in their lives and actually really making a difference. One thing that somebody said to me that like really stuck out is that people won't necessarily remember what you did or what you said, but they'll remember how you made them feel. And it's really a privilege that we get to make people feel seen and valued even at the most difficult times in their lives. I love it because there's so much variation in the job, and I'm going to go through that a little bit later. But if you don't like the same old medical ward round that lasts for 4 hours every single day doing the same thing, then you get a lot of variety in Obs and Gynae, so it's a really good option. It's currently run through training, although it may possibly change in the future. But for me, that gave me that peace of mind that once I was in a location and once I was on the training program, I'm just on it then until I'm a consultant. And there's a lot of opportunity for less than full time in Obs and Gynae too, which I think really helps if you're looking to juggle like family life or other commitments and things as well. And finally, the team in Obs and Gynae are amazing. You know, everyone's just fantastic. So if we go on to the next slide. We're going to do a little bit of a night in the life of the Obs and Gynae SHO. So this was a real night shift that I did when I was an F2. In Preston, when we were F2s, we covered Obs and Gynae on our on-calls. So I'll just fly through this and it just gives you an idea of the variety of things that you see within a shift. So you'll start handover at 8:30 and then you'll go and do a ward round of all the ladies on the delivery suite. So you're aware of everybody that's in labour. And then I had to go down to the gynae assessment unit to see if there's a few patients down there. some of them that are kind of got left over from the day because it's really busy, and some that had just come during handover. And gynae assessment unit sees things like heavy vaginal bleeding, people that are attending with miscarriages, people that are attending with ectopic pregnancies. So after I'd seen those patients down there, I then had to go back to delivery suite where I assisted with the Cat 2 section. And then after the section, I had to go straight to maternity triage, where there was a few ladies there with things like reduced movements. And there's a lady who was really unwell, and we actually started on the septic bundle. And then after that, I had to head down to the postnatal ward to rewrite the prescription charts. Everywhere else in the hospital was online charts, except for maternity when it was all paper charts. I had to go rewrite the charts. And then at 1:30, I had to go to the gynae ward. There was a post-op lady there who was scoring highly on her news chart, and they also needed some analgesia prescribing. Then I managed to grab a quick break, my lunch, at 2 o'clock in the morning. And then I headed to the postnatal ward. There's a lady there with high blood pressure. You're probably all aware of us being concerned about high blood pressure antenatally before ladies have the babies, where it can be things like preeclampsia, but that can also manifest itself postnatally in days 3 to 5 as well. So I had to go and review her for preeclampsia. And then I went back to delivery suite and I assisted my registrar with a Kiwi delivery. So that's the little suction cup on baby's head. And after that, I assisted with the perineal repair, so putting everything back together. At 5 o'clock, I had to go back to maternity triage to see a lady. She was actually a twin lady who was bleeding in pregnancy, so I had to examine her. Had a quick break, and then we more or less ended the night with another cesarean section before I then went to the gynae ward, do a bit more prescribing before handover and home. So you can see it's quite busy. And there's so much variety in terms of what you're going to do within a shift. So if we go to the next slide, this is a little bit about the variety in the week in the life of an Obs and Gynae SHO. So this is a week off my current rota. And again, it shows how even within the week, there's a lot of variety as well. So Monday, like it was for me today, was a full day of antenatal clinic. And then say on a Tuesday, you could be in theatres in the morning and gynae clinic in the afternoon. Wednesday could be your on-call day. So that's your long 12.5-hour day, and on calls is similar to the night shift I just showed you. So that's on delivery suite, looking after all the labouring women. Thursday is elective sections in the morning, and then gynae assessment unit in the afternoon. Friday, you might be on the postnatal ward in the morning and theatres in the afternoon. So there's a lot of different things that you can do within Obs and Gynae. So if we move on to the next slide, this is, I think a lot of people ask about work-life balance because they've heard a lot that work-life balance can be really bad in Obs and Gynae. So I wanted to put this on as an example of my rota. Again, this was when I was the Obs and Gynae SHO rota. This is 48 hours a week and 1 in 3 weekends, which sounds rubbish to be fair, but I think it's fairly standard across most surgical and medical specialties. Like I think any job other than GP, you're going to be working up to 48 hours a week, and that's fairly standard. You just have to get a bit clever about where you take your annual leave. Not all units are as bad as this. My current unit is it's actually quite nice. We do 43 hours a week average, and I do 1 in every 4.5 weekends on call. So it's like 1 a month. So it varies from unit to unit. I think probably just to highlight that, whereas with some jobs you do this as a junior, and then as you get to become more senior, the job gets a little bit nicer. It's probably worth bearing in mind that even as a senior, even as a senior registrar, this is what your rota is going to look like. But as I said, there is opportunity to go less than full time and to adjust this to how you want it to look. So if we go to the next slide, I thought I'd just talk a little bit about some of the difficulties within the job, because we quite often talk about all the good things. But if you are genuinely thinking of applying for Obs and Gynae, I think these are really important things to consider. So first of all, it is a very emotionally challenging job. Sometimes I drive home and I'm just like, my mind is just fried, because you've gone from maybe being in a birth, which is like the happiest moment for somebody ever, and then you have to go straight to theatre to do like a surgical management of miscarriage, and you know that's a really difficult time for that woman and she's really grieving. And then you come straight out onto delivery suite and there's somebody else who's 25 weeks delivering, and you know that baby's probably not going to make it, and then in the next door room another lady's delivering. So you know there's like these highs and lows, and you have to be able to manage those and work through them. So it's just really important to have a good support network around you, and you know have a good team that you can chat through these things with. You have to be ready to make high pressure decisions. So by the time you're an ST3, you're going to be managing labour ward by yourself overnight. Your consultant is on call on the other side of the phone, but they're not necessarily on site. They could be half an hour away. So you have to be able to make these decisions about when do you take people to theatre and what you know, what's the management going to be? There's always going to be ongoing exams, portfolios. I'm going to talk a little bit more about exams in Obs and Gynae in a minute, but there's always kind of those pressures ongoing. There are also ethical challenges for people. You know, it's worth thinking about the different things you're going to see in Obs and Gynae. And I think for everybody, we have to decide somewhere where we draw a line and where we sit with different things. So that's worth thinking about. I put this media expectations bit in after an antenatal clinic when there was quite a difficult patient who, from what she'd seen online or heard on the media, had very set ideas about what she wanted. And they were actually very, very different from what we were recommending. And it can be quite difficult when what we think is best based on medical knowledge kind of clashes with what people perceive from the media and people around them. And so it's kind of having those communication skills to work through all of that. As I've just shown you, there's long antisocial hours. And then finally, the thing that probably you're all very, very aware of is this high competition ratio and this bottleneck coming into specialty training. I think it's about 1 in 7 applicants in this last year. I'm not sure what it is in the current application, but I know that can feel a bit overwhelming and a bit scary to get into. So with that in mind, if we go to the next slide, we're going to start talking about the application process for Obs and Gynae and how to make sure that you absolutely smash it to give yourself the best chance of getting in. So I'll just briefly run through the interview process for Obs and Gynae. So first of all, you apply through Oriel, which is the same as what you applied for your foundation programs through. It's usually over a couple of thousand applicants. And then the next step is to sit your MSRA exam. So the MSRA exam, multi-specialty recruitment assessment, I think it's called. It's basically the exam that we sit for Obs and Gynae, anaesthetics, GP, pediatrics. Lots of different specialties sit this exam. So it's not specific to Obs and Gynae at all. It's a very general exam, but it's important that you revise for that really, and that you try and get as well as you can in that. 50% of it's SJT, 50% of it's clinical questions. And then basically you all get ranked on your mark. In my year, and I think this most recent year as well, the top 75 people automatically bypass interview and get offered a job in Obs and Gynae, and they're ranked 1 to 75th. And then anybody from place 76th onwards up to obviously a certain threshold will then get offered an interview. We'll go through interviews in a second. After your interview, everyone then gets a score, you're ranked, and then you preference your location, and then the first person gets their first choice of location, and it kind of works down like that until all the spaces are filled. So just having a little think about the interview. It's a very short interview for you're going to spend a lot of time preparing for it, and you're going to have done years worth of work experience to cram into this interview. But the first bit is this clinical prioritization. So generally you've got 4 or 5 stations where they'll give you different scenarios, and you have to discuss who you would go and see first and why. You also have other people on your team. So you could say, I would send the medical reg to go and see this patient. I would go and see this patient. And you basically talk through an A to E for each of them and what you would need to do. So you've got 5 minutes reading time and prep, and then 6 minutes to deliver what you would do for that. And then the next part of the interview is 9 minutes, which is the structured interview questions. And these are much more like the questions that you would expect to see in an interview. So we're going to go over those now on the next slide. These are some of the standard sort of interview questions you can be thinking of. Feel free to take a picture of this slide if you want. This is kind of the sort of things you need to be thinking of when you're having experience in Obs and Gynae, when you're doing a job in Obs and Gynae. Think about how you can pin your experiences and your learning into different ones of these so you've got answers. So for example, one of these is teaching. It's all well and good to have teaching. Most people have done some teaching for other medical students at some point. But what's important is to have feedback from your teaching so that you can reflect on it. So you can be I delivered a teaching session on X, Y, and Z. I received excellent feedback on blah, 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 and show more than you've just taught, show how you were effective in your teaching as well. Or, for example, I've also got training pathway here. We're going to talk through the training pathway in a minute. And it's just being slick at being able to reel it off so that they know that you know what you're getting yourself into. So yeah, that's just some ideas of things to focus your learning on over the next few months or however long you've got before you apply for Obs and Gynae. So if we go on to the next slide, and apologies because I know this slide's quite full, but I wanted to try and make it as informative as we could. This is the training pathway in Obs and Gynae. Some of the names in it have changed a little bit recently, but they've not made an up-to-date like matrix like picture, so I just went with this one. So you've got your F1 and 2, then after that is when you sit your MSRA exam and you apply for training, and that's your training in Obs and Gynae split into 3 stages essentially: your basic, intermediate, and advanced training. So basic training is your SHO years, it's your ST1 and 2. I put a little screenshot of my training matrix, like my requirements for ST1 and 2 here, so you can see what sort of things you'll do. ST1's fairly chill, you only have to get 3 smears done, but you can see that by the end of ST2 you have to be confident with cesarean sections, Kiwi deliveries, forceps deliveries, perineal repairs, management of miscarriages, putting in coils, taking biopsies. So there's quite a lot you have to be able to do by the end of ST2. And then also by the end of ST2, before you can progress to ST3, you have to have sat your Part 1 exam. So there's 3 exams in total in Obs and Gynae. Your Part 1, which is they call it basic clinical sciences. I've just sat it. It's not very basic, but it's all your clinical sciences. And then you have to sit your Part 2 and 3 exam by the end of ST5 before you can progress to ST6 and 7. So ST3 to 5 is very much similar sort of thing where you're building up more and more experience, more and more confidence. As I said, by ST3, you're managing labour ward by yourself overnight, being classed as a registrar. So there's a lot to like learn in your first couple of years, so you're confident with that then. And then ST6 and 7 is your advanced training, and that's where this slide's slightly out of date. So at this point, you could choose to do subspecialty training, and the 4 subspecialty options are gynae-oncology, maternal and fetal medicine, reproductive medicine, or urogynecology. And that would be, so for example, Preston is a tertiary gynae-oncology centre. These people have all done subspecialty in gynae-oncology. Often to get onto your subspecialties, you have to have done like a PhD or an MD or something like that along the way to give you enough qualification to go onto your subspec training. If you don't do subspec training, you have to do, on here it's called ATSMs. You might hear that phrase around, that's the old term. It's now called SITMs, so the specialist interest training modules. And they're like a little bit more specialized modules that you pick up and you get extra experience on along the way. So when you qualify, you kind of show that you've got a bit more of an interest in a specific area rather than general Obs and Gynae. And you can see examples of, again, they're called ATSMs on there, but the SITMs are very, very similar topics that you can pick. So you might do a bit more on medical education or colposcopy or menopause, so that you've got a specialist interest within your unit. So hope that gives you a good understanding of what basically your future is going to look like if you do Obs and Gynae training. It's a long journey, but you're learning so much along the way that I think by the time you get to ST7, a lot of people are just like, where's the time gone? So if we move on to the next slide, I thought I'd talk a little bit about what to expect as a senior, because obviously we're not going to be juniors in Obs and Gynae forever. As you get to be a senior reg, and even as you're a consultant, you've got, well, so as you're a senior reg, you've got ongoing exams, but even as a consultant, you've got other work-based assessments and appraisals and showing continued professional development. As I said, you're expected to be able to make high-pressure decisions. You're going to have continued education. So as I mentioned, for some of those subspecialties, you have to be doing PhDs or MDs. You get an increase in responsibility as you go along. So you might take charge of the teaching or the mortality and morbidity meetings, which I can talk a bit more about in a second, taking on more of a role in audit or research, all these different things. There's ongoing out-of-hours work, but as I mentioned, it is currently run through. So once you're on, and I think that gives you a nice peace of mind. So if we go on to the next slide, I thought I would talk about how you can create a really good Obs and Gynae portfolio. So again, feel free to take a picture of this slide if you'd like to. So I'll talk through basically what I did, and then there's like extra things that you can do as well. So the things that I did during university to build up my portfolio, and as I mentioned, I wasn't fully set on Obs and Gynae at the time. So if you're not fully sure that that's definitely what you want to do, these things can definitely be applied to a lot of specialties. But make sure you get some sort of audit done. I did actually do my audit in Obs and Gynae. Just don't let anyone suck you into a really difficult long audit. Just something simple, data collection's enough to show that you understand the process. If you get any options on like student selected modules or essays, always pick Obs and Gynae topics if you can. I couldn't always, because they were often the quite competitive essay titles. But as many opportunities as there is to specifically focus on Obs and Gynae, go for it. I used to work as a HCA, like a healthcare assistant, during the evenings and weekends whilst I was at uni. And I actually always did that on either delivery suite or the postnatal ward. So I think that gave me a really good experience of what Obs and Gynae was like, not just from the side of a medical student or a doctor, but also you see a lot more from the HCA side and the side of the midwives, and just being around those things. Was actually when I saw my first vaginal delivery was when I was at HCA. I got to go into the room and watch that. So that was really cool. Teaching, take opportunities both to give teaching to juniors and also to attend teaching, to attend Obs and Gynae conferences. Make sure you've got your certificate because that shows commitment to specialty. Take any leadership opportunities that you can get. That might be, for example, I was like secretary of the Paediatric Society. I didn't really do a lot, but bring out a few things that you can talk about in an interview if you need to. And finally, get stuck in on placement. It can be really, really easy as a medical student just to feel a little bit pushed in the corner, and it can be quite scary to be like, hi, like I'm so-and-so. But I'd really encourage you to like get stuck in as much as you can. Say, oh, I'm really interested in Obs and Gynae. Can I follow you around? Can I assist with the cesarean section? Can I go in and watch that delivery? Just ask. We love it when people are keen and ask and want to do it. Things that you can do during, if you're in your foundation training now, I would actually really, really recommend this top one. So this is your Obs and Gynae Basic Practical Skills course, and you can find it on the Royal College website, and different hospitals host these. Essentially, it was a 2-day course where we learn about like perineal repairs and suturing. We learn about instrumental deliveries. This course is a compulsory course by the end of ST1, I think it is. And it's actually really, really hard to get onto because there are not many runs. So if you can do it, I did mine when I was in F1. Firstly, so that I had the skills I needed when I did my job as an F2, but also then like it's ticked off now. So this year I'm not like rushing to try and find a course when it's really competitive. So that's really, really good. Some of your foundation schools will fund it. Some won't. If you're in a position to do it anyway, I would do it regardless because I really, really enjoyed it and it was really, really good. I did a couple of audits and quality improvement projects. I was involved in a national audit, and then when I was in GP, I also just did a quick local audit on HRT management, and also try and present it even if it's just locally. Try and get an F2 job if you can. If you can only get an F1 job, that's absolutely fine. But I think if you work in Obs and Gynae as an F2, you often get a lot more opportunities. So try and get a job in it and think about your reflections and your experiences. Write everything down because it's quite easy. You're gonna forget things as you go on. Offer to teach other students, volunteering at Markowski's. I was a part of this BUSOG mentor-mentee scheme where I met up a couple of times a year on Zoom with, I think she was like an ST6 or an ST7. And that was really helpful just to go over my portfolio, and she gave me advice about what else I could be doing. The Royal College have loads of lectures and e-learning that are free to access, so make sure you join on those. This is mortality and morbidity meeting. So I did one of these when I was an F2, and essentially your unit will always run these, and they look at cases that of either where patients have passed away or things really didn't go to plan, and you get to kind of pick apart what happened, what could be improved on. And this shows a really good like leadership and like management role as well. So I think I actually used this as my example for when they asked me about examples of leadership in my interview. I was able to talk about how I led this meeting. Taster weeks. So if you've got a job in Obs and Gynae in F1 or 2, you don't need to do a taster week as well. So I did my taster week in a sexual health clinic, so in other related specialties. But if you can't get an Obs and Gynae F1 or 2 job, then definitely do a taster week in Obs and Gynae and get stuck in as much as you can on that. And then also see if your local unit runs what we call a prompt course. So this is a multidisciplinary course between the doctors and the midwives. You cover obstetric emergencies. It's compulsory learning for anyone that works within maternity services to do annually. But if you can do it as a junior, then it shows, again, that commitment to specialty. Other things you can do, these aren't things that I did, but definitely things that other people do. Intercalating. It doesn't get you points anymore, unfortunately, if you do intercalate. So I would recommend only really doing it if you know definitely what specialty you want to do. But if you can find an intercalation in women's health that you're interested in, then go for it. I haven't got any papers published. I probably should have, but I don't. But if you can get any papers published or research published, that's fantastic. If you can do any other surgical skills course, even if it's not related to Obs and Gynae, that's really good. Some people are amazing. I saw one F1 recently who did her first part 1 exam, literally in F1 the other day. And I mean, I think that's crazy, but if you can do it and you want to do your part 1 early, then that's really good. It ticks it off. As I mentioned, taster days, and then you've got your other related specialties as well. I would also say that anaesthetics is a related specialty. If you could go with the Obs and Gynae anaesthetist, because you're in all those operations then as well. And as always, I know they always tell you this all the way through med school and everything else, but continue your other hobbies and interests outside of medicine, because that just makes you a really well-rounded person, and you can talk about things that you enjoy doing to like manage stress or to stay organized and to help you unwind at the end of the day. So if we move on, this is pretty much my last slide, but I essentially just wanted to say it's all well and good having all this experience and doing all these different things, but these are the things that I would expect you as medical students or as foundation doctors to get out of your time in Obs and Gynae. Like, it's no good just turning up to the ward and doing your time on the ward. These are the things that I would expect you could be doing at this stage. So first and foremost, I would say meeting people within the specialty is like so important, because I think when you meet people, they can advise you on like different opportunities, and they can help you along the way. They can help you with your interview prep, and you can talk through, if you find something really difficult, you can talk through it and you get like real life lived experience. So definitely do an Obs and Gynae, make friends with the people on your unit that you're doing it with. Skills that you can be doing. So you should be confident with doing your speculums, doing your swabs, doing your obstetric examinations, and as well as that with your surgical skills. There's no reason why you can't be really practicing your suturing and your perineal repairs, even doing a section. So my goal when I was in F2, I wanted to have done a section by the end of my rotation. And actually by the end of F2, I'd managed to do 6 cesarean sections from start to finish. So, if you tell them that you're keen to learn it, then often people will let you have a go. Laparoscopic surgery, practice your skills. If you want to get more practice at laparoscopic surgery, every Obs and Gynae unit, certainly I know within the North West, but I think across the country, should have lap sim boxes that you can just use for the day, just have a go, practicing stacking sugar cubes and things like that to get your skills up. Communication, you should have practice breaking bad news. Even if that's not you personally, you should reflect on examples of when you've seen other people break bad news, whether that was a really good example or actually a really bad example, and reflect on how that was done. You should have some knowledge of managing obstetric conditions such as preeclampsia or sepsis or reduced fetal movements. I'm not saying obviously you should be a pro at it, but definitely have an idea of how you'd manage some of those things. Make sure you're writing reflections for your logbook, but also these give you things to talk about in interview. So reflect on the workload, reflect on how you saw the registrar prioritise and juggle different cases that needed to go to theatre at the same time. Reflect on the ethics and the difficult things you saw. Reflect on consent. You probably all heard of the Montgomery case where a lady sued the hospital because essentially she had gestational diabetes and then her baby had a shoulder dystocia, and she was told that she wasn't correctly informed prior to delivery about the risks of shoulder dystocia with a big baby. And so now it's become this big thing about making sure that women are well informed. And I remember one time, one of our registrars handed over to the consultant that there was a lady that was going for induction, but after she'd discussed the risks of a big baby with her, the lady had now opted for a cesarean section. And I remember at the time, the consultant being a little bit mad, saying that she shouldn't have had that much choice. She should have just had a vaginal delivery. So that was a reflection for me that I was able to think about and I had prepared in case they asked me an interview, because it shows you real life practice of giving women enough information and not scaring women, and how we share that and enable people to make informed choices. Make sure you get involved with your audits and quality improvement projects. And finally, try to see a variety of things within Obs and Gynae. So go to different clinics, your wards, on calls, delivery suite, postnatal ward, try and get stuck in as much as you can. So I think if we go on to the final slide now, I'm not going to go through all of this, but this is just to signpost you to the Obs and Gynae person specification. Definitely have a look at this, print it out, highlight areas you need to do more on, write all over it. And this will really guide you on what experience you need. So if we come on to the final slide, it's just to ask if anybody has any questions really. And I've also put my email there if you need to get hold of me, and I'm also on social media if you want to reach out and ask me any questions as well.
Thank you very much for a really inspiring talk. We do have some questions in the group chat, so we'll go through them in turn. The first question is, when do you actually see the MSRA? Is that at the end of F2? And roughly how long do you spend preparing for this?
So the MSRA is usually in January. Not everyone sits on the same day. They release a load of dates and you have to book an exam. And it's sat in, like, you know, your Pearson VUE centres where you would do like your driving theory test, or you did your SAT before doing med school. So that's when you sit it. It's around January time, ready for interviews, which are around end of Feb, beginning of March. And then you get your offers around end of March, April time, ready to start as an ST1 in August. Everyone spends different amounts of time on it. I would say I am definitely somebody who probably over prepares for exams, because I would always rather do that than just miss out. So I think I started, if it was in January, I think I probably started around October time. Just initially not revising as intense, but definitely from like November, December, January, you want to be revising quite intensely for that.
Thank you. The next question is, do they value a taster week in Obs and Gynae higher than a foundation job like in the surgical training? Is there any taster weeks you'd recommend doing?
Sorry, do they value taster week in Obs and Gynae? So yeah, I think you're right, actually. I think, like saying surgical training, as far as I'm aware, you get points, don't you? Is that right, for doing a taster week in Obs and Gynae? In Obs and Gynae, there actually isn't a points system for things that you have or haven't done. So the only value you get from doing a taster week in Obs and Gynae is to give yourself some experiences to like reflect on, and even to find out for yourself if you enjoy the specialty. But whether you've, like say, if you've done it as an F2, you probably don't need to also do a taster week in that. So I use my taster week in sexual health as like examples of how I've seen like healthcare work together. I hope that makes sense. If it doesn't, please let me know.
Yeah, thank you. Last year, were preferences for jobs released after interviews? After interviews were all done?
Yes. So we interviewed. I'm trying to remember the order of everything now. We interviewed, and then I think we released all our preferences, and then we got told what our rank was, I think. Or it might have been we found out our rank and then we preference. But either way, you do your interview, and then later on you get sent an invitation, and you've got like a couple of weeks to rank everywhere. It takes forever, because some you just rank the deaneries, but others were like ranking specific tracks within deaneries. So I think there was about 600 or so to rank in total. So you don't have to rank them all. If you know you would only want to go to specific places, you can just rank those as well.
Thank you very much. For the next question is, do you recommend keeping a logbook, or is there an official logbook for C-sections or other skills in obstetrics and gynae?
There isn't an official one that I know of. I know there are some like general online logbooks that you can use, like similar to what people who are applying for core surgical training would use. I didn't keep an official logbook. That being said, I had a notepad and I wrote down like every gynae operation that I was in, and I also like wrote down every cesarean section that I was in, because I wanted to kind of keep track of how many I'd been in. So I had that to reference back to when it came to interview and talking about experience, but you don't have to have a specific like official logbook.
Okay, thank you. The next question is, how did you prepare for the MSRA? Any good resources?
So for the MSRA, I just used PassMed, I think it was, but like the MSRA version. My top tip for that would be, when you go on the online textbook, you can order the topics in terms of what comes up most frequently. So for example, within dermatology, you order the topics, and like acne rosacea was the top one, meaning that if you're going to be asked questions about dermatology, they're going to most frequently be about acne rosacea. So any that were more frequent, I wrote notes on. Those that just had 1+, so they don't come up very often, I didn't spend very much time. I kind of read over them, but I didn't write notes on them because there's so much to cover. So I did that, and I did all the mocks, and I think I probably did all the questions a couple of times over on PassMed. And then about a week before, I subscribed to something called eMedica. The site's quite clunky, and the questions are written in a really different way. So I hated it at first because I was getting them all wrong. But it's probably a good experience for me to see a different format of questions. But the main reason I also bought eMedica is because they've got the situational judgment questions on there as well. So they've got quite a few mocks. So I just did all the mocks, and that was the only prep that I did for the situational judgment side of the exam. So I wouldn't recommend getting that until a couple of weeks. I think I got it maybe 10 days before the exam, and I just mainly focused on the past med.
Thank you. The next question is, do you recommend adding any skills we have done during med school?
In terms of into like your logbook and things, definitely. You might find that the more you get in your logbook, the less relevant those things become because you've done like bigger and better things. But certainly, like if you've done an audit in med school, then you can definitely talk about that in your interview. They probably value it more if you've done a more recent one, but in case you've not had the chance to do anything more recently, then you can definitely talk about things you've done in med school.
Thank you. The next question is, does everyone who gets an interview get a job offer?
No, unfortunately not. I don't know the exact numbers. I feel like it might be like 1 in 2 or 1 in 3 who get an interview get a job. But like I said, I don't know the exact numbers. I feel like that's just in the back of our mind somewhere from last year. So yeah, not only is your interview important that you smash it to get your preference of where you go, but it's also so that you can even get offered a job. I should say as well, it'll say it more on the website because I can't remember the numbers exactly, but your overall score was a combination of your MSRA and your interview. So for some specialties, once you've done your MSRA and you get offered an interview, your MSRA score doesn't count and it's just purely on your interview score. But certainly on the year that I applied, both your scores are like combined. I think it might even have been 50-50 to give you an overall score for your ranking.
That's very interesting to hear. I know for a lot of specialties, you get the ranking from your portfolio only, or the ranking of your interview, and things get messed. That's really interesting to know. The next question is, what is the best way to prepare for the interview? Mine is in 2 days. Do we need to talk through every step of an A2E exam?
First of all, good luck. 2 days, you're going to smash it. I think you've only got a limited amount of time. That being said, I remember like I lost marks just because I forgot to say I would start someone on IV antibiotics. So be as thorough as you can. Often if you've missed something, they'll ask you questions to prompt you. But I remember at the end of mine, they actually didn't ask me any more questions. And I was just like, oh, is that it? Like, I don't know if that's a good thing or not. And I think generally, if they're not prompting you with anything else, then you probably covered it. I would say have a really clear structure. So I'd be like, out of these 4 patients, I would go and see this person first because X, Y, and Z. When I go to see them, I'm going to do, I would probably say I'm going to do an A2E exam. You don't need to say I'm going to examine airway, I'm going to examine breathing, but you kind of talk through briefly. I'm going to do an A2E exam. I'm going to examine them. I'm going to order these investigations. I'm going to treat them with this, and I'm going to escalate too. So that's kind of example of what you can do. Like I said, make sure you really use your the team that you've got with you. So, for example, if there's like an obviously Obs and Gynae issue patient, then send your Obs and Gynae reg. So it varies each year with what team you've got with you. But make sure you kind of know who they've given you and send the appropriate people. If it's like updating a family over the phone, that's not a priority to do. So make sure that comes at the bottom of your list. And one thing that they often try to catch you out with as well is family members asking for an update over the phone. So you already say, well, that's going to be least of my priorities because these other patients are unwell. But also remember to talk about how you would ask for consent. So, sorry, Mrs. Smith, unfortunately, I can't share any information with you until I've confirmed with Mr. Smith that he's happy for me to share that information. So that's why they're trying to catch you out, that you're not just going to get all flustered and tell them you'd update everything over the phone. So I remember that being one thing that I remember being emphasized to me when I was practicing. So just have a really clear structure. Practice speaking them out loud, and kind of know where you're heading with things. You do get given the time to prep. You're allowed pen and paper, so you can pretty much have your answers written down just to like regurgitate. So I hope that's helpful. Let me know if there's any more questions about that.
Thank you. Do you know roughly what score for the MSRA is required to get into an Obs and Gynae interview?
I'm not entirely sure. I think it obviously would vary from year to year. I got a score, I think I got 582. I think generally the cutoff is quite high. I would probably be aiming for over 500, but it would probably vary on year to year, kind of depending who else is applying. I'm not even sure where you can find out the information of like what cutoffs were, because I remember trying to look for it everywhere and I couldn't. So in the end, I just decided you've got to do the best that you can do.
Okay, thank you. And the last question we've got in the chat is, when can you do the BPS course?
So you can do the BPS course. Like I said, I did mine in F1. So it's aimed at ST1s and 2s, but they also say it's open to F1s and F2s who have an interest in Obs and Gynae. The one that I went on, we just had a poster emailed around by the trust advertising it. So keep an eye out for those sort of random emails that come to your trust inbox. And also, I think if you look on the Royal College website, I think they advertise where all the different courses are. So do try and get signed on to one of those because they were really good.
Okay, thank you. I think someone already mentioned in the group chat that they found on Reddit that the cutoff bypass this year was 592, and the cutoff for interview was 531 points.
It's so high. It's so high.
It is very overwhelming.
Yeah.
The next question is there any funding available for these courses? As the one running at my hospital later this year is £500.
It really varies. So if you do them as an ST1, you get them refunded by the college because the requirements. That being said, when you do your exams in Obs and Gynae, you have to pay for them. So my most recent exam was £550 and you have to pay for that. But the college does pay for your courses. In terms of if you do them in F1 and 2, I think it varies depending on your kind of like local deanery. So originally they said they wouldn't pay for mine. So I sent a very strongly worded email to the foundation director of the hospital explaining all the reasons that would be good. And I think it was probably just so long that he got bored. So he said that they would fund it. But I know that other people have had difficulty. Look around. I know that some courses are cheaper than others. So if any of you are in the North West, I did the course at Chorley. It was a fantastic course. And I think that one's more about £300. As I said, they are expensive. If you're able to do it, I would do it regardless of, if they'll refund you or not. But I appreciate not everybody can. So just have a chat with your foundation director, explain how it would be advantageous to you in your role, in your applying, and try and get a bit of study budget for it.
Thank you. The next message is that they join later, so sorry this was covered. What is the rota like throughout the training and after?
Yeah, are these slides going to be available afterwards?
Yeah.
We can skip back to it, but I talked a bit about, like, I gave examples of the rota and different things that we covered. So perhaps at the end we can just, in fact, if we just pop it on screen now, I guess we could flip back to those slides and you can just have a quick look at it. I won't go over it too much because obviously for everyone, so it's quite near the start. Yeah, so this is the rota. This was a rota that I had last year. So averaging at 48 hours a week, working 1 in 3 weekends. My current trust is 48 hours a week. Sorry, it's 43 hours a week at my new trust, and it's 1 in every 4.5 weekends, so 1 a month. It's fairly standard, but I mentioned that Obs and Gynae is a lot easier to go less than full time. Whereas I think in surgical specialties, it's very much looked down on if you go less than full time because they say you're not committed, X, Y, and Z. But in Obs and Gynae, it's actually a lot of people do 80% or even 60%. So it's possible to make this look a lot nicer if you would like it to look nicer.
Lovely, thank you. The next question is a follow-on question about the interview. Do we send the gynae reg before reviewing or after?
So you could say something like, initially, while I'm reviewing this poorly patient, I'd ask the reg to go and see that patient, and then I would get a handover from them afterwards. Or if you went to see the patient, you could say, I could initially go and review the patient, and then if I felt it was necessary, I could escalate to the gynae registrar, and I could do these things in the meantime. It's a little bit difficult to comment exactly, obviously, because it depends who your other patients are that you're given in your interview as to how you're going to preference them. But it's okay to say I would ask my senior registrar to go and see them, because you're working on the assumption that everyone's available to go and see them because these are the team that you've been given. So you can say, like, I would ask them to go and see them. I guess you can use words like closed loop communication and things like that to describe that you would kind of chase up on those things. You're not just sending everyone everywhere. You're going to follow, make sure that everyone's been looked after appropriately. And with your, I would actually, this is a really good point. So if you ask your junior, so they might say you're a junior reg in Obs and Gynae. If they say, if you send your F1 to go and review a patient, a really good thing to say is, and then I would ask them to come back to me and feedback to me, or, to be in touch if they had any worries. So it kind of shows your support in your junior colleagues as well. So whether you send up or down, like have that closed loop communication.
Okay, thank you. Are there any online courses for those of us abroad?
I personally didn't do any online courses, so there definitely will be, but unfortunately I'm not able to recommend any in particular because I didn't do any. There are, I would suspect on the Royal College website, I think there will be a section for international applicants, and so you might be able to find some more information on there, or if anybody else knows any, feel free.
Thank you. I think that was the last question in the group chat. Thank you very much for all the questions, and thank you very much, Miriam, for your time and for answering everything. All right, everyone. So please remember to fill in the feedback form. I just put the link in the chat as well. You're going to receive an email with it as well. If you do not fill in the feedback form, you won't receive your certificate, unfortunately. So make sure you complete that in order to have certificates for portfolio. Thank you, everyone. Sorry, there was another question that came through just now. So for the structure part of the interview, did they ever cut you off while you were speaking? Thank you so much.
So on my, I think when it was like, I can't remember the exact word of it, but it was something about like, the general why Obs and Gynae, and my answer was, I knew it was over 3-4 minutes long because I was trying to get it all in there, and they cut me off halfway through, and I felt really gutted at the time. So I was like, I've got so much more to say. But I think be reassured that if they cut you off, it means they've heard what they need to hear from you. They're not going to let you waffle on, because you've only got 9 minutes in total, and they've got about 6 or 7 questions to get through. So if they cut you off, don't be worried. Know that you've ticked the boxes that they needed you to tick. So now they're going to move you on to the next thing. And I would advise practicing your answers and condensing them so that you've got nice, succinct, you're not waffling, and you just give them what they need to know.
Okay, thank you very much, and thank you everyone for joining us. Thank you.